Hello and welcome to the Emergency Room podcast, the place where we delve into the fast-paced, life-saving world of emergency medicine. Are you ready to explore the critical decisions and cutting-edge treatments that happen daily in the ER?
All right, everyone, buckle up. We're diving headfirst into pediatric in-hospital cardiac arrest today, focusing on PLS CPR.
It's all about those crucial moments, those split-second decisions that can truly make a difference.
Right, when every second counts.
Yeah.
So let's start with the heart of the matter, those heart rhythms.
Yeah.
PEA, asystole, VF, VT.
Okay.
When we're facing a pediatric code, which of these are sending us running for that defibrillator?
Well, you got to think of it like this. VF, that's ventricular fibrillation. It's basically a chaotic electrical storm going on in the heart.
Okay,
And then there's VT, ventricular tachycardia. That one's like a runaway train.
gotcha. Okay.
Both of those, they need a good jolt, a reset. That's where the defibrillator comes in.
This FOIF and VT, we'd be shocked. Easy enough. But then what about PEA and asystole?
PEA, pulseless electrical activity, tricky one because you see electrical activity on the monitor, but the heart, it's just not pumping effectively. And asystole, well, that's the flat line, no electrical activity at all, and unfortunately, neither of those bad boys respond to defibrillation.
So, no shock for PEA or asystole. What's the game plan then?
High-quality CPR, and we got to figure out what's causing this whole mess in the first place. Treat the root cause,
Makes sense. Speaking of high-quality CPR, let's get into those compressions, especially for our smallest patients. How do we make sure they're effective, whether it's a neonate, an infant, or a young child? Each one's different, right?
Absolutely. It all comes down to knowing their anatomy. Now, for neonates, those tiny humans under a month old,
Okay.
picture this, a line connecting their nipples. Just below that, you position your thumbs encircling their chest.
Wow.
It's called the two-thumb encircling technique. Delivers the right force without causing any harm.
That's pretty amazing, really delicate work there.
It is.
So what about those slightly older infants, up to a year old?
We have options there. We can stick with the two-thumb technique or switch to 2 fingers, 1 finger breadth below the nipple line.
Okay.
It really depends on what feels comfortable for the provider while still getting those compressions up enough.
So comfort and effectiveness are key.
Exactly.
Gotcha. Now, when we move up to young children, how do things change?
From 1 year to puberty, we transition to the two-handed technique.
Oh, like we use for adults.
You got it, but with some important tweaks. Instead of the heel of your hand, use the heel of one hand, or for smaller children, 2 hands interlocked. Aim for the lower half of the sternum, steer clear of that xiphoid process at the bottom.
Right. Always got to remember their size and development when choosing the right technique.
Absolutely.
Okay, so we've tackled rhythms and compressions. Now let's hit those critical meds.
Yeah.
Epinephrine and amiodarone. In these high-stakes situations, knowing the correct pediatric dosage is life or death.
Yeah.
What are those key dosages we absolutely need to remember?
Epinephrine, that's our go-to for cardiac arrest. It's like jump-starting the heart, giving it that energy boost to get it pumping again.
Right.
The standard dose is 0.01 mg/kg given IV or IO, repeatable every 3 to 5 minutes.
0.01 mg/kg.
Remember that 0.01, and you can calculate the rest from there.
All right, 0.01 mg/kg, etched in my brain. Now, what if we have to give it via the endotracheal tube? Does the dosage change then?
Good catch. Yes, it does. We bump it up to 0.1 mg/kg for ET administration because absorption isn't as reliable through the lungs.
Makes perfect sense. Now, what about amiodarone? When does this one come into play, and what's the dosage we need to remember?
Amiodarone, that's our secret weapon for those stubborn, shockable rhythms like VF or pulseless VT that just won't quit. We hit them with an initial dose of 5 mg/kg IV or IO,
Okay.
and if needed, we can repeat with another 5 mg/kg.
All right, so epinephrine for most arrests, amiodarone for those stubborn, shockable rhythms. But meds are just one piece of the puzzle, right? What else needs to be spot on to give these kids the best shot at survival?
Absolutely. Meds alone won't cut it. It's a team effort. We need that high-quality CPR, effective ventilation, and we got to find and treat that underlying cause quickly.
So it's like a symphony, everything working together in perfect harmony.
I like that, a symphony.
And speaking of working together, communication during a code, it's paramount. How do we ensure medication administration goes smoothly? No hiccups.
Having a dedicated medication administrator, that's a game changer.
Oh.
One person focused solely on drawing up and administering the drugs eliminates distractions and minimizes errors. And clear communication, it's crucial.
Yeah.
Team leader calls out the drug, dosage, and route. The person administering confirms verbally before pushing that plunger.
Like a well-rehearsed dance, everyone knowing their steps.
Exactly.
Okay, so we've navigated those heart rhythms, mastered age-specific compressions, tackled epinephrine and amiodarone dosages.
Yeah.
What other medication wisdom do we need to impart before we wrap up this part of our deep dive?
We need to drive home the point that medications, as powerful as they are just one part of the whole picture. And every intervention, it comes with risks, especially with our young patients. We gotta weigh the benefits against those risks every single time. It's all about staying updated on those guidelines, practicing these protocols until they're second nature. And those debriefings after every code, those are gold. They help us refine our skills and knowledge so we can be the best advocates for these little ones.
Absolutely, couldn't agree more. Now let's shift gears a bit and talk about what happens after a cardiac arrest. Achieving ROSC, the return of spontaneous circulation, it's a huge win, but it's just the beginning of the battle, right?
Mm-hmm.
What comes next on the road to recovery?
You're right, ROSC, it's just the first hurdle. Now we need to focus on optimizing their physiology, creating that perfect environment for their body to heal. It's like we've pulled them back from the edge. Now we got to give them the best chance to bounce back.
So supporting their blood pressure, making sure they're oxygenating well, effective ventilation, all those critical things. What else is crucial in those first few hours after ROSC?
Temperature control, it plays a big role. The latest guidelines recommend targeted temperature management, TTM, for comatose patients after cardiac arrest.
PTM, that's where we carefully cool them down, right? I remember learning about it for adults, but what about the evidence for TTM in pediatrics?
That's a great question. And to be honest, the research is still evolving, but the key takeaway is we want to avoid fever like the plague. It can really mess with a recovering brain.
So we're basically trying to give the brain a chance to chill out, recover after such a traumatic event.
Exactly.
What about the practical side of TTM? Are there challenges, things we need to watch out for?
It's a balancing act, that's for sure. We got to monitor these patients closely for any complications, electrolyte imbalances, clotting problems, those sorts of things. The potential benefits of TTM, they're significant, especially for neurologic outcomes, but it requires a watchful eye.
So TTM, it's crucial, but it demands both precision and a keen eye for those potential complications. What else should we be on the lookout for in those initial hours after a pediatric cardiac arrest?
Seizures, they're a big concern. Sadly, they're quite common after a cardiac arrest, and they can make things worse, causing further damage to the brain.
That makes sense. How do we go about detecting and managing seizures in these vulnerable patients?
Early detection is key, but it can be tricky, especially if they're still comatose. Seizures can be subtle, so continuous EEG monitoring, that's often our best bet, helps us pick up on any unusual electrical activity.
So we're basically putting a surveillance system on the brain, making sure we don't miss anything.
That's a good way to put it.
And if we do detect a seizure, what's the plan of attack?
We got to act fast, stop that seizure activity as quickly as possible to minimize damage. Anti-seizure meds, those are our go-to weapons.
It all comes back to protecting the brain, which makes sense. It's so vulnerable after a cardiac arrest. And it's not just the patient who's affected by something like this, is it?
You're absolutely right. Cardiac arrest, it affects everyone involved, the patient, their family, even us, the healthcare providers. It's a shared trauma, and we need to address that psychological impact.
I can't imagine what it's like for a family to see their child going through something like that. How can we best support them during those difficult moments?
We need to create a support system for them, connect them with social workers, chaplains, support groups, all those resources that can help them navigate the emotional roller coaster that comes with this.
Those connections can make a world of difference.
They really can.
And what about us, the healthcare providers? Responding to a code, especially a pediatric one, it's incredibly demanding, both physically and emotionally. How can we ensure we're getting the support we need?
It can be draining, no doubt about it. Hospitals need to have systems in place to support their staff, things like debriefings after a code. They help us process the experience, identify areas for improvement, and access to mental health resources, that's essential. Taking care of ourselves, it's just as important as taking care of our patients.
It's all connected, isn't it? When we feel supported, we can provide that compassionate, high-quality care these families deserve.
Speaking of systems and resources, I recently came across the concept of cardiac arrest centers. Can you shed some light on what these are and how they're changing cardiac arrest care? Cardiac arrest centers. Now, that's interesting. I haven't really looked into that too much. What's the idea behind them?
Think trauma centers, but specifically for cardiac arrest. There are specialized hospitals equipped to provide comprehensive care to patients who have experienced a cardiac arrest. It's not just about resuscitation, it's about that long road to recovery too.
So they're bringing all the expertise and resources under one roof, trying to optimize outcomes. What kind of resources are we talking about? What sets them apart?
Well, they usually have 247 access to cardiac catheterization labs, advanced imaging, and specialists in critical care, cardiology, neurology, everyone ready to go at a moment's notice.
Wow. So they're equipped to quickly diagnose and treat the underlying cause of the arrest. That's huge for long-term recovery.
Yeah, exactly.
What about the post-arrest care? What makes these centers stand out in that regard?
They have dedicated teams, all trained in post-arrest care, things like targeted temperature management, seizure management, early rehab, you name it. They're really taking a holistic approach, focusing on all aspects of recovery. So it's a really comprehensive and coordinated approach, giving those patients the best chance to not just survive, but thrive.
That's the goal.
Is there any evidence showing these centers actually make a difference?
It's early days, the research is still coming in, but the initial data suggests patients treated at these centers have better outcomes, higher survival rates, and improved neurological function.
That's great to hear, but I imagine there are some challenges with implementing this model more widely.
Of course, geography is a big one. Not everyone lives near a cardiac arrest center, so transportation and access can be a real problem, especially in those rural areas.
Right.
And then there's the financial side. Setting up and maintaining these specialized centers, it takes a lot of investment.
It's a complex issue, no easy solutions, but it's a conversation worth having for sure. As we try to improve cardiac arrest care, exploring models like these cardiac arrest centers is essential. Now, looking ahead, what advancements on the horizon have you excited about the future of this field?
One that's particularly fascinating is the development of ultra-portable AEDs.
Ultra-portable, even smaller than the ones we see everywhere now.
Think pocket-sized. These devices are becoming more sophisticated and affordable, which could completely change how we respond to cardiac arrest, both inside and outside the hospital.
Wow, imagine everyone having access to an AED that fits in their bag.
It's pretty incredible, right? The impact on survival rates could be huge, especially for kids. Early defibrillation is so important for those shockable rhythms, and these ultra-portable AEDs could give bystanders the power to act even sooner.
It's like giving people the ability to save a life right then and there.
Exactly. And this technology could also change how we handle cardiac arrest inside the hospital, too. Imagine every nurse, every doctor having one of these ready to go.
That would definitely cut down the time to defibrillation.
And in cardiac arrest, every second counts. The faster we can shock them, the better their chances of survival and a good neurological outcome.
It's like bridging that gap between the arrest and the code team arriving.
Exactly, making everyone a first responder in a way.
This technology sounds amazing. But with anything new, I'm sure there are challenges and questions that need to be addressed.
Of course. One of the biggest is making sure these devices are used correctly. We need to teach people how to recognize cardiac arrest, how to use an AED safely and effectively. Training and clear instructions will be key.
Right, we don't want hesitation or confusion in those critical moments.
Absolutely. We also need to think about the logistics of maintaining and distributing these devices, making sure they're ready when needed. And of course, the technology has to be reliable, accurate, especially when it comes to pediatric heart rhythms.
All valid points. It seems like there's a lot of work ahead, but the potential benefits are undeniable. This is a really exciting time for cardiac arrest care.
It really is. It just goes to show how we're always striving to improve how we respond to these situations.
Speaking of pushing boundaries, what other innovations are out there that give you hope for the future?
Another area with huge potential is artificial intelligence, AI, in resuscitation.
AI in resuscitation. It sounds like something straight out of a movie.
I know, right? But AI is already making big changes in medicine, and it's only a matter of time before it plays a bigger role in cardiac arrest care.
Okay, I'm intrigued. How could AI be used in this setting?
Imagine this. AI algorithms analyzing data from the patient monitor during a code in real time, giving personalized guidance to the team.
So it's like having another expert in the room, helping make the best decisions.
Exactly. AI could help optimize CPR quality, anticipate complications, even predict the likelihood of survival.
Wow, taking the guesswork out of resuscitation.
In a way, yes. It has the potential to improve our decision-making, make our interventions more consistent and effective.
And could be used in training, too.
Absolutely. AI-powered simulations could provide incredibly realistic training, letting healthcare providers practice their skills and decision-making in a safe environment.
It's like a virtual code, but you can repeat it over and over, getting better each time.
Exactly. And AI could tailor the training, adjusting the scenarios to each person's skill level. Better training, better outcomes for patients, everyone wins.
It's amazing to think about all the possibilities. What else excites you about the potential of AI here?
The amazing thing about AI is that it's always learning. As we gather more data, refine those algorithms, it'll become even more powerful in the fight against cardiac arrest.
This is a really exciting time to be involved in pediatric cardiac arrest care.
It really is. But with all this amazing technology, we can't forget about the human element that's still so important.
What do you mean by that?
No matter how advanced our technology gets, it's still the compassion, dedication, and quick thinking of the healthcare providers that ultimately makes the difference.
It's about technology and humanity working together.
Exactly. Using technology to improve our skills, but never losing sight of that human touch. It's essential.
That's a great way to put it. Well, we've covered a lot of ground today, from the basics of PLS CPR to all these incredible advancements shaping the future. I hope our listeners feel empowered and inspired to keep learning and advocating for the best possible care for these kids.
I hope so too. Remember, knowledge is power, and in this case, it can truly save a life.
Thank you so much for joining us on this deep dive into pediatric cardiac arrest. Until next time, stay curious, stay informed, and stay ready to make a difference.